section of the pathology review for the USMLE Step 1. Most peripheral neuropathies are inflammatory neuropathies. That is, that there's inflammation of either the peripheral nerves, the peripheral nerve roots, the autonomic ganglia, or the autonomic nervous system. However, the inflammatory neuropathies can either be infectious or autoimmune. The most famous inflammatory neuropathy is Guillain-Barré syndrome, also called acute inflammatory demyelinating polyradicular neuropathy, or AIDP. You can think of AIDP, or Guillain-Barré, as sort of like MS of the peripheral nervous system. There's demyelination of the peripheral nerves. If, in the case of Guillain-Barré, there is relapses and remissions, just like MS, then it's no longer acute inflammatory demyelinating polyneuropathy, but rather chronic inflammatory demyelinating polyradicular neuropathy, or CIDP. But the idea here is that Guillain-Barré is an inflammatory neuropathy that is demyelinating. And the incidence is about 1 to 3 per 100,000, and the pathogenesis is much like that in MS. There are activated T cells that are an autoimmune response against myelin. Now, just like we had perivenular demyelination in MS, we have perivenular demyelination in Guillain-Barré. That is, that the white cells surrounding the nerves are able to leave the blood supply, leave the bloodstream from the low flow areas of the venous system and cross over into the nerve area to cause demyelination. So you see perivenular and endoneurial lymphocytic infiltration. Of course, being peripheral nerves, there's a lot of remyelination that can occur as well, allowing regeneration and regain of function. Interestingly, Guillain-Barré usually is preceded by a viral illness, either as an upper respiratory tract infection or a lower viral gastroenteritis, or an immunization. And it is thought that there is a process of molecular mimicry where there is some kind of foreign antigen that activates the immune system and stimulates it to attack the myelin. There is something about the antigen, the foreign antigen, that mimics part of myelin and therefore activates the immune system to attack it. Most patients with Guillain-Barré present with an ascending weakness or ascending paralysis. The weakness usually begins in the feet and gradually over the course of days or weeks may move up the legs. It may go as high as the neck. Here you will have respiratory problems as well. The key finding on exam in patients with Guillain-Barré is loss of reflexes. So when you tap and you've lost ankle jerks and the patellar reflex, and you have a patient who's got ascending paralysis, you're most likely dealing with a patient with Guillain-Barré. In terms of workup, you can do a lumbar puncture, and what you may find is a CSF albuminocytologic dissociation. High protein, but normal cells. That's telling you that there's something going on in the CSF, but there are no white cells to be found. Why? Because they are not in the central nervous system. Those white cells have left the central nervous system and are attacking the peripheral nervous system. They've left the CSF and they are now attacking the peripheral nerves. CIDP, like I said, is a relapsing remitting condition much like MS. These patients present with a symmetric mixed sensory motor polyneuropathy. They will have recurrent demyelination and remyelination, and if they have multiple episodes, then patients with CIDP begin treatment, although slightly different than those used for MS. Infectious neuropathy includes leprosy as a cause. Here you have a skin infection with the peripheral nerve disease caused by Schwann cell invasion by the Mycobacterium leprae. Segmental demyelination and remyelination occurs, as can axonal loss. And here you get progression to endoneurial fibrosis with multi-layered thickening of the perineural sheaths. These patients present with a symmetric polyneuropathy, usually a stocking glove distribution. You also have prominent pain fiber involvement leading to traumatic injury These patients don't sense pain in their lower extremities as the nerves aren't working properly. They will develop foot deformities after recurrent injuries, traumatic injuries to the feet. Another infectious cause of neuropathy is diphtheria. The interesting thing about diphtheria is that it's not the bacteria that causes it, but rather the toxin made by diphtheria that causes the peripheral neuropathy. Here the patients again present with paresthesias, numbness, tingling, burning, but also weakness of their muscles. And when you look at their nerves, you will see segmental demyelination. Again, treatment of the diphtheria should, in essence, help with the neuropathy. Another infectious neuropathy is varicella zoster, or VZV. This virus is the one that causes chickenpox. And what happens once you've had chickenpox is the virus becomes latent and goes and hides out within the dorsal root ganglion. However, for one reason or another, 30 or 40 years later, after having had chickenpox, this virus becomes reactivated, travels down the peripheral nerves to the skin where there's an eruption of a vesicular rash, much like that in chickenpox. This rash will be in a dermatomal pattern. That is, it will only occur in an area innervated by the single nerve. Once that occurs, the patient then can develop what's commonly referred to as shingles. And a sequelae of shingles is post-herpetic neuralgia. That is, that there is so much trauma to the nerve based on the shingles that the nerve no longer functions properly and gives you a constant irritation and painful sensation. It's called post-herpetic neuralgia because VZV falls within the herpes virus family. Most frequently, this disorder occurs in the thoracic and trigeminal dermatomes, either on the face, in the back, or on the chest. And as mentioned, it resolves usually without any problems, but can have that post-herpetic neuralgia as its sequelae. There are also some hereditary neuropathies that I'd like you to keep in mind. The most important one is Charcot-Marie-Tooth disease. This is a hereditary motor and sensory neuropathy. And in this case, the patient can have both motor complaints and sensory complaints, either one or together. Other hereditary neuropathies include Dejerine-Sodas and Riley-Day, which are not as important to remember, except for the fact that Riley-Day includes an autonomic neuropathy as well, where patients can have constipation, gastrointestinal problems, problems with body temperature regulation, as well as cardiac arrhythmias. And there are inherited metabolic diseases that can cause neuropathy secondarily to the metabolic problem. Charcot-Marie-Tooth disease, as I mentioned, is a very important hereditary form of neuropathy due to mutations in a protein called myelin protein 22. Here you have repetitive demyelination and remyelination of the peripheral nerve, giving rise to onion bulbs on the peripheral nerve. The myelin here is undergoing remyelination over and over again because the first few times are unsuccessful. And so the body keeps trying to remyelinate, and in so results with this onion bulb, or multi-layers of myelin. The clinical findings for Charcot-Marie-Tooth are peroneal muscular atrophy, where there's atrophy of the calf muscle. Autosomal dominant inheritance is classically seen for Charcot-Marie-Tooth, and the most common complaints are sensory paresthesias, numbness, tingling, as well as weakness secondary to motor deficits. Patients can also develop an orthopedic problem due to imbalance in the neuromuscular tone of their feet, and that orthopedic problem is called pes cavus, which is a deformity of the foot. Diabetes, a very common disorder, has three distinct forms of peripheral neuropathy associated with it. First, a distal symmetric sensory or sensory motor neuropathy. This is the classic stocking glove sensation of numbness or paresthesias in the feet, and then going on to include the hands. There's also an autonomic neuropathy that can occur where the autonomic nervous system is not functioning properly. And the patients can develop gastroparesis and constipation. And finally, focal or multifocal asymmetric neuropathies can occur, where the patient could, for example, have a Bell's palsy or a unilateral third nerve palsy. This, in this case, would be a pupil-sparing third nerve palsy, as opposed to a pupil-involving third nerve palsy, which would be due to an aneurysm. Most commonly, the first two, the distal symmetric sensory or sensory motor neuropathy and autonomic neuropathies, are seen together. Pathologically, you'll see segmental demyelination of axons, as well as thickening of the arterioles. These patients will present again with autonomic dysfunction such as gastroparesis, constipation, failure to regulate body temperature correctly, as well as distal sensory motor neuropathy. This is an electron micrograph showing you a cross-section of myelinated fibers. What you should see are thick, dark, round circles around the axons, but the arrow is demonstrating a large axon that has no myelin around it. And if you look around, you'll see a few others where there's no myelin around them, and that is classic for diabetic neuropathy. Finally, there's thiamine deficiency and vitamin B12 deficiency. Thiamine deficiency is usually secondary to alcohol use. You usually think about Wernicke-Korsakoff syndrome with thiamine deficiency, but you can also have a neuropathy, and that neuropathy is dry beriberi. So the buzzword here is dry beriberi, which is a non-specific peripheral neuropathy that presents with a toe drop, foot drop, and or wrist drop. That's due to thiamine deficiency. Vitamin B12 deficiency is a subacute degeneration of the posterior columns as well as the lateral corticospinal tract. It's usually worse in the lower extremities, and it can be seen in patients who are pure vegetarians as well as those who have pernicious anemia. And here, replacement of the B12 will help alleviate their symptoms due to posterior column dysfunction, which includes loss of proprioceptive sensation in the legs. Finally, paraneoplastic neuropathy is caused by the presence of a tumor anywhere in the body and the immune system's reaction to it. Again, just like the molecular mimicry discussed in Guillain-Barré syndrome with a foreign viral antigen, tumor cells can also express antigens that are in the incorrect location, activating the immune system. And again, through the process of molecular mimicry, the immune system can attack and cause demyelination within the peripheral nervous system. This is a paraneoplastic syndrome because it looks like it's coming from the neoplasm. It is a diffuse symmetric peripheral neuropathy manifested as weakness as well as sensory deficits, and the most common tumor associated with paraneoplastic neuropathy is small cell lung cancer. This ends the peripheral neuropathy section of the pathology review for the USMLE.